Hello, everyone. My name is Dr. Naomi Chapelton, and I have been practicing internal medicine and geriatric care for over 22 years. In that time, I have sat across from thousands of patients, men and women in their 60s, 70s, 80s, and beyond, and I have watched them trust their doctors, trust their pharmacists, and trust the labels on their medication bottles. That trust is something I take extremely seriously, which is exactly why I decided to make this video today. Because there is something that has been troubling me for a long time, something I see in clinical practice far too often, and something that most people over the age of 60 have never been properly warned about. Today I am going to talk to you about a category of medications that, in elderly patients, has been directly linked to serious cardiovascular damage to the heart. And I want every senior watching this to understand what I am about to say, because this information could genuinely protect your life or the life of someone you love. Before I go any further, I want to be completely transparent with you. Everything I share in this video is for educational purposes only. I am not your personal physician, and nothing I say here should be taken as a substitute for the advice of a qualified medical professional who knows your full health history. Please always consult your own doctor before making any changes to your medications. What I am offering you today is knowledge, the kind of knowledge that I believe every patient deserves to have before they walk into a doctor's office or pick up a prescription at the pharmacy. Now, with that said, let us begin. When we talk about heart health in the elderly, we are dealing with a fundamentally different landscape than we are in younger adults. The aging heart is not simply an older version of a young heart. It has undergone real structural and functional changes over the decades. The walls of the heart become stiffer. The electrical conduction system, which regulates your heartbeat, becomes more vulnerable to disruption. The kidneys, which are responsible for clearing medications from your body, become less efficient with age. And the liver, which metabolizes so many of the drugs we prescribe, also slows down. What this means, in very practical terms, is that a medication that is perfectly safe and well tolerated in a 40-year-old can become dangerous, even toxic, in a 75-year-old, even at the same dose, even with the same diagnosis. This is one of the most important and most underappreciated facts in all of geriatric medicine. So when I say that there is a medication, or rather a class of medications, that I believe seniors should approach with extreme caution, I am not being alarmist. I am being precise. And the class of medication I am referring to today is NSAIDs, non-steroidal anti-inflammatory drugs. You know these medications. You have taken them. Ibuprofen, naproxen, diclofenac, indomethacin. These are some of the most widely used drugs in the world, available over the counter in every pharmacy, in every grocery store, sometimes even in vending machines. They are taken for headaches, for arthritis pain, for back pain, for muscle soreness, for menstrual cramps. Millions and millions of people take them every single day without a second thought. And for many people, in the short term, they are effective and relatively safe. But for older adults, especially those with any pre-existing heart condition, kidney issues, or high blood pressure, the story is very, very different. Let me explain to you exactly what happens inside the body when an elderly person takes an NSAID regularly. These drugs work by blocking a specific enzyme in the body called COX, cyclooxygenase. And by blocking this enzyme, they reduce the production of prostaglandins, which are the chemicals responsible for inflammation and pain. That is their intended mechanism of action, and it works. The problem is that prostaglandins do not only cause inflammation and pain. They also play a critically important role in regulating blood flow to the kidneys, maintaining the protective lining of the stomach and intestines, and, most relevantly for our discussion today, they help regulate the constriction and dilation of blood vessels throughout the body, including the vessels that supply the heart. When you block prostaglandin production with an NSAID, you do not just turn off the pain signal. You interfere with all of these other vital functions at the same time. In the kidneys, this can cause fluid retention. The body starts holding onto sodium and water instead of excreting them. As this fluid accumulates, blood volume increases. Blood pressure rises. And for an elderly heart that is already working hard just to maintain normal circulation, this additional pressure can be the thing that pushes it over the edge. We call this decompensated heart failure. And I have seen it happen to patients who had no idea that the ibuprofen they were taking for their knee pain was the cause. They come in with swollen ankles, shortness of breath, fatigue, and they say to me, "Doctor, I have no idea what happened. I have not changed anything." Except they have. They started taking ibuprofen 3 weeks ago, and that small, seemingly innocent change set off a cascade of physiological events that landed them in my office, or worse, in the emergency room. But the cardiovascular effects of NSAIDs in elderly patients go beyond fluid retention and elevated blood pressure. Multiple large-scale studies, and I want to be very clear that I am talking about peer-reviewed, published medical research, have shown that regular NSAID use in people over 60 significantly increases the risk of heart attack and stroke. A major analysis published in the British Medical Journal looked at data from over 400,000 patients and found that the risk of heart attack increased substantially within the first week of taking high-dose NSAIDs. Within the first week, not after years of use, within days. The risk was highest with diclofenac and ibuprofen, two of the most commonly used over-the-counter pain relievers in the world. And the risk was even higher in patients who already had heart disease, high blood pressure, or diabetes, which describes the majority of my elderly patients. Now, I want to pause here for a moment because I know that some of you are sitting there thinking, "But Dr. Chapelton, I have been taking ibuprofen for years and nothing has happened to me." And I understand that response completely. When we do not see an immediate, obvious consequence, it is very human to assume that something is safe. But this is precisely where the danger lies. Cardiovascular damage from chronic NSAID use often accumulates silently. The blood pressure creeps up gradually. The kidneys lose function slowly. The heart muscle becomes progressively stiffer. You may not notice any of this until the day something acute happens: a heart attack, a stroke, a hospitalization for heart failure. By that point, the damage has already been done. This is what we in medicine call a silent risk factor, and it is one of the reasons why I feel such a strong responsibility to talk about it openly and plainly. I also want to address another medication in this category that many seniors use and that carries a specific, often overlooked cardiac risk: diclofenac. Unlike ibuprofen, which is available in relatively low doses over the counter, diclofenac is often prescribed in higher doses by physicians for conditions like osteoarthritis, one of the most common conditions in older adults. And while it is highly effective at reducing pain, the cardiovascular data on diclofenac is, to put it plainly, concerning. Studies have consistently shown that diclofenac carries a higher cardiovascular risk compared to other NSAIDs and compared to acetaminophen, which is an alternative that I will discuss in a moment. In Denmark, a countrywide study found that diclofenac use was associated with a significant increase in major cardiovascular events, including heart attacks, even in patients who were otherwise considered low risk. Denmark, I should note, actually restricts diclofenac from over-the-counter sale, partly because of these findings. The United States has not gone that far, but the evidence is there, and every senior should know about it. Now, I also want to talk about the interaction between NSAIDs and two other very common drug categories that elderly patients frequently take. The first is anticoagulants, blood thinners, such as warfarin, or the newer direct oral anticoagulants like rivaroxaban and apixaban. Many of my older patients are on blood thinners because of atrial fibrillation or a history of blood clots. When you add an NSAID to the picture, the risk of serious bleeding, including gastrointestinal bleeding, and critically, bleeding around the brain, increases dramatically. I have had patients who were stable on their anticoagulant for years, took a few days of ibuprofen for a toothache without mentioning it to their doctor, and ended up with a GI bleed that required hospitalization. This combination is genuinely dangerous, and I cannot stress that strongly enough. The second category is ACE inhibitors and ARBs, medications that are very commonly prescribed to elderly patients for high blood pressure and heart failure. NSAIDs can blunt the effect of these medications, making your blood pressure harder to control, and they can also significantly worsen kidney function when combined with these drugs. It is a combination that cardiologists and nephrologists actively warn against, and yet it happens constantly in clinical practice because patients do not always tell their doctors about the over-the-counter medications they are taking. This brings me to something I want every single person watching this video to do. I want you to make a complete list of everything you take, every prescription medication, every over-the-counter pill, every vitamin, every supplement, and bring that list to your next doctor's appointment. Not just the prescription medications, everything. Because the interactions between common over-the-counter drugs and prescription medications are a leading cause of preventable hospitalizations in elderly patients, and most of those hospitalizations could be avoided with better communication. Your doctor cannot protect you from a drug interaction they do not know exists. You have to be your own advocate here. So now you may be wondering, if NSAIDs are so problematic for elderly patients, what should I take instead for pain? And this is a very reasonable and important question. The answer depends on the type and severity of your pain, and it truly requires a conversation with your own physician. But I can give you a general framework. For mild to moderate pain, headaches, minor muscle aches, mild arthritis pain, acetaminophen, also known as paracetamol or Tylenol, is generally a much safer option for the heart and kidneys in older adults. It does not have the cardiovascular risks that NSAIDs carry. However, it does carry liver risks at high doses, particularly in patients who drink alcohol, so it is still not something to take carelessly or in excess. Topical treatments are another excellent option. Topical diclofenac gel, for example, applied directly to the affected joint, delivers the medication locally with significantly less systemic absorption, which means much lower cardiovascular and kidney risk compared to taking a pill. Physical therapy, gentle exercise, heat or cold therapy, and in some cases, low-dose corticosteroid injections are other approaches that may provide relief without the systemic risks of oral NSAIDs. There are also non-NSAID oral medications for chronic pain conditions like duloxetine, which has evidence for certain types of chronic pain and does not carry cardiovascular risks. Again, these are conversations to have with your doctor. I am not recommending specific treatments here. I am simply opening up the space for those conversations to happen. I also want to spend a moment talking about a scenario I see frequently in my practice, and that is the elderly patient who has been taking a daily low-dose aspirin for years, either prescribed by a previous doctor or self-prescribed, and who also takes ibuprofen periodically for pain. Aspirin, even at low doses, has its own antiplatelet effect. It makes the blood less sticky. And when ibuprofen is taken at the same time, it actually interferes with the antiplatelet action of the aspirin. This means that patients who are taking low-dose aspirin, specifically to protect their heart, may be unknowingly canceling out that protective effect every time they take ibuprofen. This is something the medical community has known about for years, and yet it is very rarely communicated to patients. If you are on low-dose aspirin for cardiovascular protection, please talk to your doctor about whether you should be taking ibuprofen at all. And if you do need it, ask about the timing, because the order in which you take the two medications matters. I want to circle back now and talk about something that is not purely pharmacological, because I think it is important for the bigger picture. One of the reasons that NSAIDs are so widely used, especially in older adults, is that chronic pain is genuinely underdiagnosed and undertreated in this population. Arthritis, back pain, neuropathy, these are extraordinarily common in people over 60, and they significantly impact quality of life. When pain is not adequately managed, patients reach for what is available, what is cheap, and what works. And that is often ibuprofen or naproxen from the drugstore. I am not here to criticize anyone for doing that. Pain is real, and the desire to relieve it is completely understandable. What I am saying is that if you are chronically reaching for over-the-counter NSAIDs to manage your pain, that is a signal that your underlying pain condition deserves more comprehensive attention than it is currently receiving. Talk to your doctor not just about the medication, but about the pain itself. There are often better, safer, more sustainable solutions available, and you deserve access to them. Let me also briefly mention one more medication that some seniors use for pain and inflammation: ketorolac, which is sold under the brand name Toradol. This is an NSAID that is often given by injection in emergency rooms and urgent care settings for short-term pain management. It is extremely potent, and the FDA explicitly states that it should not be used for more than 5 consecutive days and should be used with great caution in patients over 65. Unfortunately, I have seen it used beyond these limits in older patients, and the consequences for the kidneys and cardiovascular system can be severe. If you are ever given this medication in an emergency or urgent care setting, please ask how long you will be taking it, and make sure the prescribing provider is aware of your age and any existing heart or kidney conditions. I want to close by coming back to something very fundamental. The fact that a medication is available without a prescription does not mean it is harmless. The fact that you have taken something many times before without a noticeable problem does not mean it is safe to continue indefinitely, especially as your body changes with age. The fact that your neighbor or your friend takes it every day does not mean it is right for you. Your cardiovascular system, your kidneys, your liver, these change as you get older, and the medications you take need to be reconsidered in the context of who you are today, not who you were 20 years ago. That is why I encourage every senior watching this video to have an honest, thorough, up-to-date conversation with their physician about every single medication they are taking, including the over-the-counter ones. Ask about the cardiovascular risks. Ask about the kidney risks. Ask about interactions. Ask what your alternatives are. You have the right to that information, and any good doctor will welcome those questions. My name is Dr. Naomi Chapelton, and my goal with this channel is always the same: to give you the kind of honest, detailed, evidence-based information that helps you make better decisions about your own health. If this video was helpful to you, I hope you will share it with a family member or a friend who might benefit from hearing it. And if you have questions, please leave them in the comments below. I read them, and they often inspire future videos. Take care of yourselves, and I will see you in the next one.